Good afternoon, everybody. It's my pleasure to welcome all of you to today's webinar. Thank you for your interest. Thank you for joining us today. I'm Rumiana Dimova. I'm Associate Professor from Medical University of Sofia, and together with Alfredo Caturano, who is Assistant Professor at San Raffaele Open University in Rome, will moderate today's webinar on behalf of the ESD Academy. We'll guide you through the session and then try to manage the Q&A part at the end. Today, it's really my great pleasure and honor to introduce to you our distinguished speaker, Professor Markus Laimer. Professor Laimer currently is a Deputy Director and Head Physician for Diabetology at INSEL's University Hospital in Bern. He's a clinician scientist with a very strong background in both clinical care and research. He studied medicine in Innsbruck and then completed 2 years basic research following his medical degree. He received his habilitation in 2009 and has been placed in Bern since 2014. His main areas of focus are diabetes technology, and lipid metabolism. And today we have the privilege of hearing from Professor Marcos, who will share with us his expertise and his insights in one really very hot topic, the topic who is on the spotlight of clinical research nowadays, namely on SGLT2 inhibitors in type 1 diabetes. So please join me in welcoming Professor Laimer. Marcus, the floor is yours.
Thanks a lot, Rumiana. Alfredo, it's my great pleasure to give this talk on a topic I'm really interested in. It's SGLT2 inhibitors in type 1 diabetes. The SGLT2 inhibitors have been approved for type 1 diabetes, and then the approval has been removed in 2021. I will come back to this later. And we are still a little bit in conflict, in inner conflicts about the use. We know there are difficulties, especially regarding the DKA risk, and I will hopefully can give you insights in the clinical use and pathophysiology and physiology behind ketoacidosis, and also to give an outlook where we can move forward and maybe bring these drugs also in a broader way for people with type 1 diabetes. So first of all, I have no conflict of interest, but maybe there's one conflict I have, and I'm not announcing this quite frequently, but it's also important to also give awareness for type 1 diabetes. And when I was younger, as you can see here, and now I'm much older, I wanted to push the limits. And one of my goals was to do windsurfing, which was a little bit tricky. And here you see me after surfing my car pushing Apple, which I really needed. So maybe one conflict of interest, I will sometimes like to push things forward. So type 1 diabetes, this is not a single entity. There are various shades of the disease. It's not a singular state. There are different people, different treatment possibilities now in our new era with technology. There are a lot of shades, also residual insulin production and so on. So we don't have, at least in my perception, not a singular entity. This is a variety, and maybe we'll come back to this also later. When should be treatments, especially SGLT2 inhibitors, implemented? It's maybe more an individual approach needed. We still have a gap in the optimal treatment for type 1 diabetes, especially when there are complications already established. So you can see here quite nicely the difference between people with type 1 diabetes and no complications due to cardiovascular and cardiorenal complications on the left, and cardiovascular complications, cardiorenal complication also in B on the right, and the mortality, the total mortality, it's the figure A, and the cardiovascular mortality in B. And especially as soon as complications are there, or people have complications, the mortality is still high compared to control. So there is a gap where treatment needs to be optimized. And we have, now I go to the next, SGLT2 inhibitors. SGLT2 inhibitors, you know, they're quite clear. It's kind of easy way to get rid of glucose over the urine. SGLT2 is a high capacity, low affinity transporter for glucose and potassium and sodium. And most of the excreted glucose into the primary urine is reabsorbed to save energy. And SGLT2 inhibitors block this, and all of the glucose is then secreted, which was primarily secreted, is then secreted over the urine. SGLT1, most of the SGLT2 inhibitors have mainly an affinity to SGLT2. There's sotagliflozin with also an affinity to SGLT2-1. SGLT2-1 is a high affinity and low capacity transporter, so only a little amount of glucose is reabsorbed. It's also in the intestine, but you see it's about 10% which SGLT1 is reabsorbing, and it's mainly the loss of glucose over the urine what explains the glucose lowering effects, mainly the glucose lowering effects. There are other effects we will later mention. Important in this case, it's independent of insulin. So this is the one oral agent to treat diabetes which is not dependent on insulin. So it works also in total insulin deficiency. So let's have a look on efficacy data of SGLT2 inhibitors, in this case, dapagliflozin. The DEPIC trials was DEPIC-1 and DEPIC-2, published here, DEPIC-1 in 2017, and you can clearly see the potential to lower HbA1c even quite short after the treatment initiation. After 4 weeks, you already see a significant reduction of HbA1c, around 0.5% for dapagliflozin. So even 5 milligrams and 10 milligrams, the efficacy is quite the same. And here are it's an overview, a meta-analysis of several SGLT2 inhibitors. It's empagliflozin, sotagliflozin, dapagliflozin, and canagliflozin in type 1 diabetes. And you see it's a class effect. All the SGLT2 inhibitors are capable to reduce HbA1c. So they are efficient to reduce HbA1c, and this is important because that's a way to improve glycemic control. What has also been described in the DEPIC trials, that total daily dose, so insulin needs and insulin dosage was reduced. So people in this trial needed or used less insulin. So this could be good because you're losing glucose by urinary excretion. But we will come to that later. Low insulin could be also a problem. So now in the DEPIC trial was pre-AID system era. It was mainly pumps and MDI and sense-augmented pump treatment. But nowadays we are more and more using AID systems, and they become more and more routine or that's a very good development, routine treatment or the state-of-the-art treatment in type 1 diabetes. So and this is a publication of Professor Haidar in Nature Medicine, which looked at not only glucose efficacy due to glucose, but it also looked at on patient-reported outcomes, distress related to treatment. And it was a 2-by-2 study design where hybrid closed loop system was compared with sense-augmented pump therapy compared to placebo. And you see that glycemic control was significantly improved for both closed loop treatment and sense-augmented insulin pump treatment. And also the distress, so patient-reported outcomes. This also always an important point in trials nowadays, at least for me, is reduced. So it helps people to treat type 1 diabetes. And in this small trial, they have not seen any severe adverse events, but they've seen improved time in range, 75.5% versus 69%. So, and total insulin was comparable between the SAP and the closed loop treatment in this study. So now get back to positive effects and all the nowadays well-established use cases for SGLT2 inhibitors. In this case, you can see pooled data from the DAPA-HF study and the DELIVER data set. These are patients with heart failure. And you see, despite these patients had no diabetes, there was a significant reduction on a variety of outcomes. And of course, we think or we're convinced that patients with type 1 diabetes would also benefit, especially if complications as heart failure or renal disease are established, would benefit from these substances. But we don't have hard outcome studies yet. Here's a post hoc analysis of UACR, urine albumin to creatinine ratio in the DEPIC trial, and this was a follow-up trial or for the 52 weeks study extension, and you can see that UACR is decreasing quite quickly, which is clear beneficial in fact, but EGFR didn't decline. And these are really promising results, but it was a post hoc analysis. The study was not powered for that, so this is more a signal, but the hypothesis that these medication also would be helpful for type 1 diabetes is clearly established. Now, the saga of approval and withdrawal again. 2019, I already mentioned this, the EMA approved dapagliflozin, and there have been some protocols established to avoid DKA in patients under treatment. And 2021, AstraZeneca did the withdrawal of the approval voluntarily. kind of a pharma company politics, but I don't want to lean out too much. It was mainly focused on the decision on the DKA risk, and of course they mentioned the burden of safety programs. It was stated that the safety programs are too cumbersome, it's too much of controls needed. It's too dangerous, It's too the risk for DKA with all the safety measurements in parallel. This was the main cause. One can think of the outcome trials on patients without diabetes, and maybe also the data on heart failure and kidney diseases in mind. Maybe they also didn't want to take the risk to have a warning on the label. Would have been happened if the approval for type 1 would be ongoing, especially when they got approval for other diseases. So now to the safety outcomes. What are the main problems in the use of SGLT2 inhibitors? And you see it's the side effects we all know: urinary tract infection, genital mucosis. This is nothing we can not deal, and we are quite eager to do this in all our patients with type 2 diabetes. But the main problem, as you saw, is the increased risk for diabetes ketoacidosis. In these trials, it was approximately 2 to 10-fold elevated. It's not the same for all trials. In the DEPIC trial, the first, it was about 2.1-fold elevated, but clearly increased risks for DKA. So pathophysiological, what's the problem and why is the risk elevated? As I already stated, the SGLT2 inhibitors lower plasma glucose by promoting urinary glucose loss. And this reduces, as you also see, as you've seen, insulin needs, and insulin doses could be decreased by patients. And we assume that lower insulin and also leads to an increase in glucagon levels, and the kidney glucosuria. We have stated mainly a glycemic benefits of the glucosuria. Ketone clearance is postulated recently also to contribute to the DKA risk, and volume depletion due to natriuresis. Lower insulin levels promote lipolysis. You have more fatty acid influx into the liver, which leads to a higher ketone production in the liver. So it's a kind of circle which fuels itself to increase ketones. And especially in acute illnesses or sickness, diarrhea with additional loss of fluids and even further volume depletion, you get elevated ketone bodies. And it's a little bit complicated because or not complicated, we recently also have seen that, especially we've seen it in the animal model, that beta-hydroxybutyrate dehydrogenases 1 is elevated by SGLT2 inhibitors, and that this enzyme, which also shifts from acetoacetate to beta-hydroxybutyrate, that this might also contribute to the elevated risk of DKA. And yeah, and acetoacetate and shifts to beta-hydroxybutyrate. You have more and more ketone bodies, and euglycemic decay, the worst case scenario, it's pH below 7.3, beta-hydroxybutyrate levels above or bigger above 3, and glucose below 11. This is euglycemic decay, but you are all really comfortable about the pathophysiology and the decay, how decay is classified. So now we have the problem that this is the normal way decay established, and SGLT2 inhibitors elevate the risk by, in addition, elevate glucagon levels, in addition, increase ketone production, and reduces ketone clearance. So next, what ways do we have data how different factors contribute to this elevated risk for ketoacidosis? And this is a really nice meta-analysis with a meta-regression analysis where they looked which parameters influence the most on the development on ketoacidosis in people with type 1 diabetes. And this meta-regression means there was multivariable model calculated, model 1, 2, and 3. And in each model, they added another factor or another parameter to predict the or the chance or the risk to develop a DKA. And as you can see here, we have you see there are mainly 3 parameters which significantly increase the risk. It's a BMI above 27. Yes, it's a BMI above 27. It's an estimated glucose disposal rate below 8.3. And it's the amount of insulin reduction. And also significant is the volume depletion event, so the state of volume depletion. And maybe some of you can remember the Stitch protocol there, and the approval, dapagliflozin was mainly approved for patients with a higher BMI, but these analyses showed that maybe especially in patients with a higher BMI with insulin resistance reflected by the eGDR below 8.3, and therefore more substantial insulin reductions, that these patients are at higher risk for ketoacidosis. And there has been also some nice studies on short-term effects with withdrawal of insulin in type 1 diabetes using SGLT2, in this case dapagliflozin. And see here, you can see the treatment with dapagliflozin, and patients were insulin completely deficient. This was insulin perfuser study where at 0.0 no insulin was on board anymore, and you can clearly see the glucose levels are increasing over time. 12 individuals did the study for 3 hours, and 5 participants did the study period for 8 hours without insulin. This is a long time, and you can see here the capillary and ketone bodies and the beta-hydroxybutyrate levels and also the fatty acids and bicarbonate levels. And you see ketone bodies increases over time. And after, it's a small study, 5 individuals, that's clear, but after 8 hours, you see ketone bodies get into the, so to say, real risk state above 3. We will come back to this later, but we see, of course, there's an increase in ketone bodies, which elevates the risk for ketoacidosis. So now let's get to the point where we talk about treatment in daily practice and what should we do with our patients um, in situation. How do we need to prepare them? And it's also important to be prepared. All our patients, they have their DKA prevention kit, beta ketones. They are recommended to be measured in the capillary blood, especially with SGLT2 inhibitor treatment, urine ketone bodies, as they reflect mainly acetic acid that can underestimate the risk for ketoacidosis. You all know this, the recommendations regarding, it's of course not the recommendation for the use of SGLT2 inhibitors, but these are the ketone level recommendations. We want levels below 0.6. The risk is increased between 0.6 and 1.5. And already there, if ketone bodies are elevated, even there, some safety measurements, insulin injection, correction of elevated glucose levels, but also fluid intake and carbs are strongly recommended. So let's summarize one of the most important things, what really I was interested to read this article recently published in the JAMA. It's real-world data, how many patients or people with type 1 diabetes use SGLT2 inhibitors. And in this case, also GLP-1 receptor agonists were looked at. These are US data, or this is US data, and it's reflecting approximately 50% of the American population. It's EHR record. EHRs were used for this. And you see that SGLT2 inhibitors are used not that frequent as GLP-1 receptor agonists are, but especially in patients, and you can see this on the right-hand side, with cardiovascular disease, approximately or nearly 8% of people with type 1 diabetes use SGLT2 inhibitors. So we clearly can see that off-label use is still, people still use this in type 1 diabetes, and especially those with higher cardiorenal risk. That said, the EMA withdrawn approval and the FDA have never approved it due to the concern the medication is still used by patients. And of course, it is quite safe if you be aware of the elevated risk and if you educate your patients adequately. So, but what are outlooks and what do we keep in mind to keep these agents or adjunctive treatment in type 1 diabetes more used and safer used in more patients? And one thing is promising results also from a recent study where the working group of Betos et al., they looked at SGLT2 inhibitors and glucagon receptor antagonists, and they've seen that glucagon receptor agonists not only led to a small reduction in or brought a reduction in insulin needs. It also reduced beta hydroxybutyrate levels. This is the withdrawal of when the beta hydroxy butyrate was measured after withdrawal of insulin, and you see you have the SGLT2 only subgroup and you have the SGLT2 with the GRA and compared to the baseline results, you see the significant reduction in beta-hydroxybutyrate after once weekly GRA application. So promising medication to reduce risk for DKA. But what do we need to have to use SGLT2 inhibitors in type 1 diabetes safely? Some really important things are always if used, no prolonged fasting, no excessive alcohol consumption, regular application of insulin, and good education regarding sick day rules. Because if ketone bodies increase, it's always the same, enough fluid, insulin, important, and at some points, especially if there are problems with gastrointestinal problems, diarrhea, then at some points also early admission and IV fluids. But normally, with a good education and stopping of the medication during sickness and ketone body measurements, it's quite safe to use. What do we need for the future? Of course, we would be happy to see more possibilities to monitor ketone levels. So ketone monitoring strategies, possibly ketone sensors compared to glucose sensors we have. This would be quite a dream. We need better risk assessment tools, and we also need predictive biomarkers to see which patients are at higher risk. We need simple treatment strategies for the patients, and most important, we need ongoing clinical research to get more information of the pathophysiology, to get more information how we can avoid DKA and how we can identify patients at the highest risks. And we are really happy that we got recently one of our manuscripts accepted in Diabetologia, which looked at patients with type 1 and hormonal regulations in type 1 diabetes. So I will soon come to the end. And one important thing is always what Hippocrates has said, primum non nocere. It's one of the important things. First of all, we are not allowed to harm. But at some points, also avoidance of treatments could be harmful. And we as professionals, at least from my perspective, and we have the tools and the knowledge to identify patient, and of course it's off-label and I don't recommend it in general, but we have the tools to use SGLT2 inhibitors in selected patients with adequate monitoring of ketone bodies safely. And I'm deeply convinced that this group of medication, SGLT2 inhibitors, have their role also in type 1 diabetes treatment. And now I'm happy for a discussion, questions, and thanks for your attention.
Thank you very much, Professor Laimer, for this delightful presentation. I believe there is no question in the question board. So if you want to ask something to Professor, just write down your questions and we will read for you. I will probably start with one because what I wanted to ask you about was about the ketoacidosis. Sorry. In particular, if there are any sign that might you believe that that patient could develop a ketoacidosis in the next future. I mean, in one day. So if you see that these patients, you may think, okay, this is at a higher risk compared to the others in few time, not just in 1 year expectations.
Mm-hmm. Yeah, you mean that whether in the short term DKA is the risk is increased?
Yes,
So
if I see this, if for instance I'm at outpatient clinic, I see these patients today. Is there any sign that I believe that this patient is at increased risk, not
Mhm,
in the long term, but in
mhm,
short term?
mhm,
So I believe tomorrow I have now signs that in the next hour, so or tomorrow, he will develop something.
mhm. We don't have the biomarkers or the the measurements to evaluate the risk or predict the risk also in the short term. And we know we have patients on SGLT2, they measure their ketone bodies quite frequently, and also they see that at some points ketone bodies increase without really sickness or reduction in carbs. Most of the time, it's clearly what my impression is, it's clearly the volume depletion, maybe too less of fluids, too less inputs of fluids. Ah, Most of the times we see some kind of other illnesses which brings the ketone levels really above the threshold. Most of the times it's kind of diarrhea is the most common things where patients might take the medication too long, or even the onset of the event is too short. And to be honest, in all our patients, we treat it in studies and at our outpatient clinic, we've never seen a DKA. In educated patients, we always, all DKAs in type 1 we've seen were connected to ongoing treatment, even though there was a significant illness, reduction in insulin dosing, and not adequate reaction. At some points, also, patients are at this point, they feel sick, they see the quite normal glucose levels, then they are reluctant to give insulin. And we always see this cases where it's a combination of maybe too less education, maybe a lot of too much trust in the glucose levels, and then less insulin. Because if as soon as you give insulin and you add fluids at an early stage of ketone body elevation, you can stop it. That's it.
Thank you.
There are some questions coming up from the audience. So the first one is, do you have a suggested monitoring strategy for ketones?
Yes. Strategies is always because it's off-label, so strategies. Our recommendation is after starting the medication, measure ketones at least daily for at least 1 month. And the more comfortable you are with the treatment and your ketone measurements, then you can reduce it to situations where you have clearly, if you feel not good, of course, but then if you see less extended period of fasting, maybe one drink too much, or also other illnesses. And then we always recommend monitor and stop. If you're not sure, stop the medication. And if ketone levels are above 0.6, we recommend repeated measurements. And that in nearly all of the cases, they see the elevation, and as soon as insulin is given enough fluid, it's going down. And if they feel well enough, it's always good to eat some carbs too. So measure it once daily, first months, and then you can extend the period.
There are additional questions. One says, do you have an established protocol for deciding insulin adjustments? Is it taught to the patient?
No, I tend to not adapt insulin, especially with the AID systems. The systems adapt the insulin on their own, but that's why I showed the work of Haidar et al. It's the insulin, it's lower also with the AID systems, but the systems adapt themselves. And with no AID systems, I would not reduce insulin. Try it first without reduction, because hypoglycemia risk is not really elevated, at least from my perspective. And first of all, at least if I introduce it, I always recommend the patients to continue the normal insulin dose, see how whether they see some flattenings in their glucose profiles, and normally I recommend no adaptation. But we don't have the data. We see it in the studies. They reduced insulin because of avoidance of hypoglycemia, but I'm not sure whether the risk of hypoglycemia is the problems, especially if patients are using a sensor.
And another question about complications. You showed quite promising data about the reduction of A1C, but is it related to data confirming reduction of complications? So do we
No,
have such data?
we don't have hard evidence. We have only the post hoc analysis of the randomized controlled trials, but especially in heart failure, kidney disease, we've seen the big data, the post hoc analysis. I think that we need data on that. I'm quite convinced about that, and we will see some data for sure in the future. Till now, I think that the effects on especially cardiorenal protection, why should it not work for type 1 diabetes, even because of the heart failure risk is definitely increased, especially after long-lasting disease. And I would be really surprised if outcome data wouldn't show a beneficial effect, but we don't have the hard data.
Yes, and there is one more related question, which I'm also interested in, about RCTs evaluating cardiovascular and renal outcomes, because we know that our patients with type 1 diabetes are with same cardiovascular risk, but they are somehow neglected now because we don't have such a protective therapy for this population. So how you will comment the STEAN-1 trial, for example?
Yes. I don't know, honestly. What's your Umiana, what's your thought about that?
I think that this huge gap in the treatment of type 1 diabetes and in the whole strategy, because we all know the increased cardiovascular and renal risk in these patients, and I think that they should be equal to other population as without diabetes or with type 2 diabetes. So cardio-renal protection should be equal to those parts. So for me, I'm really very much looking for the results of this study and to push these protective therapies in this population.
Absolutely agree. We are talking about this since years now, and we are pushing this, and we are pushing, or we cannot push, but we try to convince also the companies to, after the withdrawal of the approval, this was a real pity, because it was suddenly we hadn't had a kind of at least framework where we can give it. I'm totally convinced that I hope for good data as soon as possible. Totally agree. We should not, and that's why what I meant by saying um, to giving this last slide with the primum non nocere. At some points, also to not give a treatment could be harmful, and at some points in selected patients, I'm totally convinced too, and I hope we will get the data as soon as possible. Sure.
There are two questions related to the ketone monitoring. The first one is, do you think continuous ketone monitoring system will change the indication? And the other one is, in countries where it is not available, the blood ketone tests and only urines, how often should be tested the BHB in blood in laboratories? This is the only option.
Yeah, I think keto monitors would be a great way to give more safety in the use, especially in patients where we think of elevated risks due to several reasons, where we think the benefits are high, but we have risks. I would be really happy to see some keto monitors. Regarding the measurements, due to the shift of acetoacetate to beta hydroxybutyrate, urine levels of ketones are often underestimated in DKE, and they are not sensitive enough. So we recommend clearly the capillary measurements. If they are not available, it's hard to say because frequent IV measurements are also bothersome, and the measurement should be available at any time. And I think this would be a big burden to, at least for me, to prescribe a patient SGLT2 inhibitors if I don't have capillary ketone measurements available for the patient.
I was also wondering about, in this case, also for sport, because these are all young patients many young patients with type 1 diabetes, and most of them are also into sports. So the use of SGLT2 inhibitors could anyway increase the risk of ketoacidosis in patients during sports. Do you suggest anything?
We did a study on that in physical exercise and use of SGLT2s. We are currently analyzing the data into that. I don't think that ketoacidosis levels in sport are elevated per se. The problem with exercise and most of patients, athletes, especially if you do exercise more rigorous over a longer period of time, I have never had a patient who has problems to get into problematic states of ketoacidosis. Our data, we are analyzing it, and maybe we can give some inputs on that.
I
It's
will
not
look forward.
maybe it's ketone bodies are also a fuel for energy, and if you use the energy, it's always good, and also ketone bodies. And we will see our data soon. And I've also seen a nice real world, real life evaluation. Yeah, we don't see ketoacidosis if we use SGLT2 inhibitors in well-educated patients. We don't see them. Yeah.
Yeah, so we start with different shades of type 1 diabetes, and probably here again, we coming to an end again, we should reconsider that this is a point of personalization, personal medicine, some different subpopulations who are more appropriate for such type of treatment. So yeah, individualization nowadays for me is one of the pills, one of the tips of our modern therapy in type 1 diabetes. So we don't have any other comments and questions from the audience, and we are coming to the end of this webinar. Thank you once again, Professor Laimer, for this really very exciting talk. It's of great interest, as we can see from the audience. Thank you all of you for participating, for your activity. Wish you good luck, good evening, and see you through our next webinars. Bye-bye to everybody.
Thank
Thanks
you
a
very
lot.
much to everyone. Bye bye.